Acute coronary syndromes, also known as ACS, represents a critical spectrum of clinical conditions ranging from unstable angina to myocardial infarction. This section focuses on the rapid identification and life-saving management of patients experiencing cardiac ischemia. Understanding ACS is vital because timely intervention directly correlates with heart muscle preservation and improved patient survival rates. We will explore the pathophysiology, diagnostic tools like the ECG, and the specific pharmacological and mechanical interventions required to restore blood flow to the heart. This comprehensive guide serves as a standard for emergency cardiac care protocols. Recognition of ACS begins with identifying classic symptoms, like substernal chest pressure, which may feel like a heavy weight on the chest. This pain often includes radiation to the neck, jaw, or left arm, and is frequently accompanied by nausea and a profound sense of impending doom. However, we must also look for atypical signs, particularly in specific populations. Women and diabetics often present with shortness of breath or extreme fatigue rather than the traditional crushing chest pain. Recognizing these subtle variations is critical to ensure that these high-risk patients receive immediate diagnostic testing and are not overlooked in the triage process. Immediate emergency department care involves specific protocols to stabilize the patient. Oxygen should be administered only if the oxygen saturation is less than 90%, or if the patient shows signs of respiratory distress. Aspirin is a cornerstone of treatment, requiring a dose of 162 to 325 milligrams. It must be non-enteric coated, and the patient must chew it to ensure rapid absorption. Nitroglycerin is given as a 0.4 milligram sublingual dose every 5 minutes for up to 3 doses. However, do not use nitroglycerin if the blood pressure is low or if the patient has recently used medications like Viagra or Cialis. Understanding the ECG is essential for determining the type of ACS. A STEMI, or ST elevation myocardial infarction, indicates a complete blockage of a coronary artery and requires immediate reperfusion. An NSTEMI, or non-ST elevation MI, typically signifies a partial blockage, where there is evidence of heart damage through the elevation of cardiac enzymes, despite the lack of ST elevation on the monitor. Finally, unstable angina is defined as chest pain occurring at rest or with increasing frequency. Unlike an MI, unstable angina does not show an elevation in cardiac enzymes, but it remains a high-risk condition that requires close monitoring and further intervention. Reperfusion goals are set to minimize heart muscle damage through strict timing. PCI, or percutaneous coronary intervention, is the preferred method for opening blocked arteries. The door-to-balloon time goal for PCI is 90 minutes from the moment the patient enters the hospital. If PCI is not available within 120 minutes of first medical contact, fibrinolytics, often called clot busters, are used instead. For these pharmacological interventions, the door-to-needle goal is 30 minutes. Adhering to these specific timeframes is a key quality metric in emergency cardiac care, as every minute of delay results in further myocardial necrosis and poorer patient outcomes. Adjunctive treatments provide additional support during the stabilization phase. Morphine is used for chest pain that remains unresponsive to nitroglycerin, though clinicians must use it with caution in cases of NSTEMI due to potential interactions. In addition to pain management, beta blockers and heparin are standard components of the treatment regimen. These medications are usually started once the patient has been stabilized within the hospital environment to help reduce the workload on the heart and prevent further clot formation. Together, these therapies complement the primary reperfusion strategies to optimize the long-term recovery and cardiac function of the patient.